Greetings and a warm welcome to all the dignitaries present here. I'm Shreyashi from Planet, serving as the allocated session assistant to ensure a seamless experience. Planet stands as India's most delightful.
Shreyanshi, some echo is there.
Okay, just a minute. Okay, sir. So, is it fine now?
Yeah, that's fine.
Okay. So, it is with great pride that Planet serves.
Still there is
as the-
echo, sorry. Still there is echo.
Just a minute, sir.
Oh, is there a background noise?
Maybe, ma'am.
Okay.
It's better now, ma'am?
Still it is there. In your background, it is a issue.
Is it Uma madam? Are you muted?
I'm muting everyone.
Okay.
Better, ma'am?
No. In your part, Shreyashi, in your part, it is there echo. Yeah, now it is stopped. So it is on your part only.
Shreyansi's background is there is a noise.
Okay, ma'am. I will take just 1 minute. We'll hand over the session, then I will mute myself.
Yeah.
Okay, yeah. So it is with great pride that Planet serves as the digital partner for this event, hosted by the National Neonatology Forum Gujarat. And the focus of today's session is lessons from expert, the first golden hour of the preterm infant. So let's begin today's session, for which I would like to invite Dr. Biraj ma'am to take over. Over to you, ma'am.
Yeah, thank you, Shreyansi, and good afternoon to all of you for this today's session of Pathshala. Again, at the same time, we are meeting. And today, this is an expert talk, and we are going to start with the preterm series with the first talk by Dr. Pratima, that is first golden hour management of preterm infants. And I request my president, Dr. Yogesh Parikh, sir, to address the audience and start the session.
Thank you, dear Dr. Biraj. Respected chief guest, our own Dr. Uma Nayak, madam. Guest of honor, my dear friend Dr. Naveen Bajaj, our distinguished faculty member Dr. Pratima Anand madam, our esteemed colleagues, dear friends, and the EB and OB members of our NNF Gujarat. It is our joy and pride to welcome all of you to launch of this neonatal Pathshala Preterm series. This is the first program on this Preterm series, the flagship academic initiative of NNF Gujarat. And today we are here virtually to learn from the experts. And this series mainly designed with a very clear vision. And I thanks Dr. Biraj for the starting of this Preterm series to learn from the experts, to practice evidence-based approach, and to improve bedside decision making for our most vulnerable patients, preterm members. So this first session, the first golden hour of the preterm care, set the tone of this journey. The golden hour is not just a clinical window; it is a window of hope, where the timely intervention can transform outcomes and the future. By focusing on this crucial period, we empower ourselves to deliver care that is quality care, that is both with the both compassionate and what is the scientifically sound. So I extend my heartfelt gratitude to our expert faculty, Dr. Pratima Madam, for guiding on this very vital topic. My sincere thanks to our chief guest, Dr. Uma Nayak Madam, guest of honor, Dr. Naveen Bajaj, whose presence adds inspiration and strength to this academic program. The initiative reflects the spirit of Team NNF Gujarat that believes in the unity, transparency, and the service. I am proud of to acknowledge and dedicated efforts of the Dr. Biraj Thakkar, our secretary, and Dr. Svetal Bhatt, project in charge, whose vision and the hard work have brought this series to life. I also thanks Dr. Kunal Aya to supporting this preterm series. So friends, neonatal Pathshala is not only the CME series. It is a movement of the knowledge sharing, a platform where every pediatrician and neonatologist can sharpen the skill, exchange the ideas, and contribute to the well-being of the preterm babies. Together, we are shaping not only clinical practice but also the future of neonatal health of the Gujarat. So let us embrace this journey with the enthusiasm, discipline, and compassion. May this series inspire us to deliver excellence in our NICU, every district, and every corner where the preterm baby fights for the life. So with these words, I declare the preterm series inaugurated. Today, the first session. Let us learn, let us practice, and let us improve because every preterm newborn deserves nothing less than our very best. So thank you, Jai Hind and Jai NNF and Jai IAP also, AOP Gujarat. Thank you. Over to you, Biraj.
Yeah, thank you, sir, for encouraging words. And now I request Dr. Uma Naik, madam, who is our chief guest. It is my privilege to introduce her. She's a distinguished neonatologist with her vast experience in neonatal care, teaching, and research. She has been a mentor to many young pediatricians and has contributed significantly to advancing the neonatal practice in this region. Madam is probably the founder member of the NNF Gujarat, one of the founder member of NNF Gujarat. And we are truly honored to have her as the chief guest. Uma Madam, welcome you all, and I request you to address the delegates.
Thank you, Viraj, for your kind words. Am I audible? Am I audible?
Yes, ma'am, you're audible.
Yeah, okay. Thank you so much. And anytime, anything, if NNF Gujarat invites, I'm so honored because I think it's my own body. As you said, I am a founder member. I, with Madam Mani and Dulari Madam and Sheila, we started it about two and a half decades ago. And I can see that the group has grown so much and the youngsters are doing so much. And I'm very, very happy to see the growth of Gujarat NNF. I must, this year with the presidentship of Dr. Yogesh Parikh and you, Dr. Biraj, being the secretary, I'm sure we're going to go to newer heights. And this is a good idea of starting preterm related material as a series. I think we're planning it as a series, right? Viraj?
Yes.
Yes.
Yes, yes.
Yes,
This is the
ma'am.
first
Yes,
one.
ma'am. Yeah.
Yeah. Yeah. So that I think that idea is very good because the golden hour we take up and then we take up the details of other problems with the preterm. And I hope a lot of youngsters, students, and the younger generation staff, as well as some SRs, are taking advantage of this. And because neonatal Pathshala always delivers something which is very unique and very new. And I'm waiting to hear Dr. Pratima Anand because I came to know about her. I don't know whether she knows me personally when she was part of the NNF Shine when I was at Parul. I recently retired from Parul, and that is how I came in touch with her. And just for information, that I was instrumental in building the present form of the NICU, including the beginning of the milk bank at SSG Hospital, Medical College, Baroda, as well as the whole of pediatric department and the NICU at GMERS Kotri, as well as the whole of the Department of Pediatrics, NICU, as well as the milk bank at Parul. And they are on the way to starting DNB neonatology. So I feel very happy to have been the backbone of all these three things. And I'm extremely happy to be here with you all. Thank you, Yogesh bhai. Thank you, Biraj. Thank you, Shwetal and others. Thank you so much. I'm looking forward to the talk.
Yeah, thank you, madam. Thank you very much for joining. And still, I remember 25 years back, you and the Dulari madam encourage youngster like me, योगेश भाई आपके जैसे लोगों को एनएनएफ में आना चाहिए. I think in the Delhi somewhere you have told me and Dulari madam. So thank you, madam, for
Absolutely.
encouraging. Yeah.
And now you are heading the body. So nice.
Thank you, madam. Thank you.
Thank you, madam, for encouraging words for your growing baby. This is like NNF Gujarat. So now it is my honor to welcome Dr. Naveen Bajaj sir and introduce him. Dr. Naveen Bajaj sir is a DM neonatologist and he's currently practicing at Ludhiana. He's a director at Sapling Hospital. Sir is the president of NNF Punjab, and he was a immediate past president of IAP Neonatology chapter. Sir has many publications. He is also an editor in chief and manual of neonatal nursing. He has contributed to many chapters in various books, including the Cloharty Manual of Neonatal Care. He had been faculty to various national and international conferences, and he has many publications too. So, welcome, Dr. Naveen Bajaj, sir, and thanks for accepting our invite. And I request you to address the audience with encouraging words and some blessings for the Pathshala.
Thank you, Biraj, for nice words and Dr. Yogesh for inviting me here. And Gujarat has always been the leader, and it has been the leader for last almost 2 decades now, and probably will be in all fronts. That includes all fronts, business, politics, and academics also now. So it is good to interact with you all. And as Dr. Yogesh said, the preterms are most vulnerable population in pediatric care. And first, our golden care is a window of opportunity for the neonatologist to do their best and as gentle and as early as possible. It is a window of hope, as we have said, window of hope for the parents because they are already being stressed with the news of impending news of being going to have a preterm baby who's going to remain in NICU depending upon the maturity for many months maybe, and it is a window of opportunity as well as hope for the newborn who's landing in our NICU looking at us and hoping that he or she is in the best of our hands. A very important topic, and Dr. Pratima, as you all know, she is a neonatologist uh, in Delhi and has been a faculty in Senses workshop, being a leader in many of the workshop, as Madam has said, the Shine workshop of NNF. And I'm sure we all are very eagerly waiting for her to start the session. Over to you, Dr. Pratima and Dr. Biraj. Yeah.
And Biraj,
Yes, sir.
Naveen is a very great connection with the Gujarat.
Oh. Sir,
I
अब
told
बता
you.
भी दो क्या great connection. I don't know, but still, when
Everlasting,
don't leave it
everlasting.
suspense.
No, my actually Dr. Rekha Udani is a Gujarati when I was doing DM in Mumbai, and now the HOD at home is also from Gujarat.
That is the biggest connection. HUD at home is a Gujarati. Okay, thank you, sir. And without much delay, I introduce Dr. Praful, who is a pediatrician and associate professor at GMC Surat, and he is my backbone for coordination and execution of this program. And he'll take this program further. So, Dr. Praful, now over to you.
Thank you, Dr. Viraj. It's my privilege to introduce our project in charge, Dr. Shwetal Bhatt. She is a associate professor, Department of Pediatrics, Government Medical College, Baroda. Also, she is a president, Women's Wings, AOPG. She was held a post of president as well as secretary in NNF Gujarat in the past. Also, she held a post of secretary, Women Wing, AOPG, as well as post of EB AOP Baroda in 2022, 23, 24. She is also a faculty of many national training like FBNC, NSSK, Advanced and Basic NRP, IYCF. She is also a great teacher from the Baroda Medical College. She is an undergraduate as well as postgraduate teacher since the last 23 years. And she also won so many this awards in a paper and poster presentation in various national and the state and national conference neonatology as well as a pediatric conference. So, ma'am, welcome you and also address the delegate and also welcome the our eminent faculty, Dr. Pratik. Ma'am, over to you.
Thank you so much, Dr. Praful. It's my great pleasure to be a project in charge for the expert series. As while working as a president NNF, I have come across some of the great academicians in NNF, which I would like to invite them, and so that NNF Gujarat can have experience sharing from them. Their expert views can be shared with NNF Gujarat delegates and members. While me and Miraj were discussing regarding this expert series, I said, let us start with the preterm because increasing population of preterm is there, especially more and more in the tertiary care center as well as the SNCUs, we are getting preterm. So, and there was a latest new guidelines for the NRP. So for that, recently Dr. Somshekar sir has shared the publication which is going drafted the just day before the discussions. That Dr. Pratima was one of the co-author and key person for that. So what best we can have from her. So I thought of inviting her. She is good friend of me since I think 4 5 years. We are now working together in NNF with different projects, and she is consult. She has done her DM neurology from AIMS. She is consultant at Lady Harding Medical College DM neurology department. She has a wonderful writing skill, and she has multiple more than 55 research papers are there. Her core interest is neonatal sepsis, preterm nutrition, growth, NRP, and quality improvement. If you search the literature, you will get a lot of variety of publications authored by Dr. Pratima. And I am very thankful to Dr. Pratima immediately accepting my invitation for the expert talk. Thank you so much, Dr. Pratima. Whenever I approach you, you're always ready, and that's really, and I'm really very privileged to have you as a friend in NNF. So over to you, Dr. Pratima, for the expert talk.
Thank you. I think good afternoon, everybody. Thank you, Dr. Biraj, Dr. Naveen, Yogesh sir, Uma ma'am. Yeah, I remember, ma'am, Gujarat was one of the leading states in Shine, and not only Shine, in the previous NNF activities also, which we did together. Thank you, Shwetal ma'am, for always remembering me. And I think I'll start with my presentation. And great to be the opening person for this preterm series. So, are you able to see my screen?
Yes, we are able to see. Your
Yes.
slides are visible. Just make it a slide
Yeah, I have made
presentation
it full
view.
screen.
Now done. Done.
Yeah.
Yes.
And I hope I'm audible also. I'm clear.
Yes, clear. Very
Yes.
clear.
Okay. Okay. So we'll start with the golden hour. And as Naveen sir said, it's the hour of hope, the first hour. And whenever we travel or whenever we just go with our families or in our conferences, meetings, the golden hour in nature is what? It's the precious time just after sunrise or before sunset when it casts a warm, soft light, gives a ray of hope, and is the precious time of half an hour, 1 hour, which is there which actually exposes the nature and the most what to say golden time of the nature. So the same concept actually comes across in the field of medicine and healthcare. The concept first started with trauma, where the trauma patients were actually supposed to be shifted as early as possible to decrease their mortality. And it was a concept was given by Adam Scowley from University of Maryland, and it was adapted to rather newborns by Reynolds in 2009, back in 2009, where they collected a bundle of interventions, evidence-based interventions, and they applied it as a quality improvement. And they showed that if these things are done in a systematic manner in the first 1 hour, it actually reduces a lot of morbidities as well as mortality. So a lot of, we know the preterm baby is vulnerable to a lot of morbidities, including intraventricular hemorrhage, bronchopulmonary dysplasia, ROP. So these all were found to be reduced with these interventions. So, what is the concept of golden hour? It's a philosophical approach that reinforces communication and collaboration, both inter and intra team, using some evidence based protocols and procedures which are already established. and they are standardized as much as possible, as many elements are standardized as possible during the time of delivery and initial management after birth. So classically, it applies to all the newborns, including term and preterm. Term newborns, mein what do? We do skin to skin care, we start breastfeeding, we keep them warm. So those are some of the things which we do in a term newborn. But this concept has much more importance in preterm babies, and all the more so in very preterm babies who are less than 32 weeks, because a lot of literature shows that those who are very preterm, very low birth weight, they are much more susceptible to these adverse effects if the standardized procedures are not done. So today we'll be focusing on the golden hour in preterm neonates, especially those who are less than 32 weeks, because most of the evidence, most of the reviews, most of the quality improvement studies, they have showed improvement in less than 32 weeks much more than the other group of preterm babies. So going back just to the physiology of a preterm baby, they have poor energy stores, so vulnerable to hypothermia much more. Immature tissues that may be damaged more easily by oxygen. Chest muscles, respiratory muscles, they are weaker and they may limit the adequate ventilation, and hence they require some support. But the skill is how to give the support as gently as possible. We know the nervous system and the brain, they are immature, just leading to poor respiratory drive, not only to poor respiratory drive, but also to complications like intraventricular hemorrhage, periventricular leukomalacia, and all these seeds are sown right at the time of the delivery. They also are prone to having surfactant deficiency, thus may need some interventions. And total blood volumes and all are less, so they are predisposed to a lot of late complications like anemia if the interventions are not done properly and in an evidence-based manner. So what are the key components of golden hour? Golden hour not only start with minute zero, but anything starts with minus. Timeline starts in minus. That means we need to be prepared, whether it's our exam, whether it's our conference, whether it's a CME, whether it's a management of a baby. So it all starts with T10, minus T10, minus T5. So the preparation is very important. Then begins the 0 minute, 0 to 10 minutes, where the important steps are thermoregulation, cord management, and the resuscitation as per the protocol. Next 10 to 30 minutes should be focusing on how to transport the baby as early and as stabilized way as possible to NICU and receiving the baby properly in the NICU. That's the admission part. And the last 1 hour, 30 minutes to 1 hour, actually should focus on the compromise status of the baby and should stabilize the respiratory and the cardiovascular systems. Start nutrition as early as possible, and all this while the two key components are keep talking to the family, keep communicating with the family, keep communicating with your team members throughout this 1 hour, and always follow the asepsis chain. So let's see how to anticipate and prepare for a baby who is preterm or a very preterm baby. So the ideal thing would be in utero transfer, which is proven to be evidence-based intervention to reduce the mortality. Then comes the pre-golden hour management. Once the mother is with you in the hospital, some of the neuroprotective and some of the protective strategies one should focus on. These themselves are a separate topic altogether, like antenatal steroids, magnesium sulfate, counseling the parents in a stepwise manner, team briefing, and equipment check, which should be a part of your preparation and the pre-golden hour management, and these things should be covered. In utero transfer, just to emphasize, the odds of reducing the death or major morbidity is 3.86. Mortality reduction is as high as 2.4 times, and especially for the babies who are extremely low birth weight babies, the reduction is as high as 3.5 times. So whenever you get a mother who is high risk at a predisposed to having a preterm delivery, it's better to advise the mother to get the delivery done at a hospital where there is a tertiary care and ICU with all the facilities available, and it's again from the published literature. So now we start with the first 10 minutes of the golden hour. So each minute is important, and we'll see how to do the evidence-based interventions in the first 10 minutes. And as I said, the key ones are thermoregulation, cord management, and resuscitating the babies who need some form of resuscitation. Since we are talking of preterm babies who are less than 32 weeks, we presume that all babies will require some assistance during the time of delivery and immediate postpartum period. So temperature regulation, it's very, very important. Everything in newborn starts with T. We start with ABC, but in newborn we start with T and it starts with TABC. It's an independent marker of morbidity and mortality. To emphasize, even 1 degree fall below 36 degrees Celsius on admission, the mortality increases by as high as 28 to 30%. Not only mortality, we have seen many times there are a lot of immediate adverse effects like hypoglycemia, tachypnea, respiratory distress, PPHN, peripheral vasoconstriction, decreased cardiac output, decreased myocardial contractility, subsequently leading to metabolic acidosis, anaerobic metabolism, and the baby may actually go into a decompensated state. So temperature regulation is first and foremost, and let's see how to do it. We all know the 10 steps of warm chain, and it particularly applies to the babies who are less than 32 weeks and in preterm babies. So what does it start with? It starts with keeping the delivery room warm. India NRP says and the Indian guidelines say to keep the temperature of the room between 25 to 28 degrees Celsius. The latest ILCOR and the COSTER guidelines, the resuscitation group, they advise the temperature to be anywhere above 23 degrees Celsius, the room temperature of the birthing area. Immediate drying, placing the baby if the baby is vigorous as far as possible on skin to skin care contact. Early breastfeeding or colostrum feeding for babies who are preterm, late preterms. Again, delaying the bathing, appropriate clothing, rooming in, keeping the mother and the baby together. Transportation, warm resuscitation, keeping the baby warm during cord management is another challenge. And of course, training the healthcare providers in the labor room, birthing area, as well as in the NICU is very, very important. So let's focus on now the facts and the evidence. What are the interventions which are actually recommended or suggested by the COSTER 2025, the evidence-based guideline group, which has formed the International Liaison Committee for Resuscitation, and it has given the guidelines for newborns also. So they have divided the group into less than 34 weeks and more than 34 weeks. So our focus is today on less than 32 to 34 weeks babies. So let us see what all to do stepwise as per the evidence. Use the room temperatures of more than, this is straight from that evidence table and the evidence document. Use the temperature of the room should be more than 23 degrees Celsius. Use plastic bags or wraps and head coverings. So head covering has been given a lot of emphasis in the guidelines, and use of caps is very much recommended in preterm babies. In settings, especially where the temperatures are low and hypothermia on admission is a significant problem in your unit, sometimes we may additionally use thermal mattresses. Always remember that whenever you are giving delivery room respiratory support or CPAP, the gases should be heated and humidified. So that also is a point of emphasis in the recent guidelines. Regarding the skin to skin care for less than 34 weeks gestation, the evidence is very low certainty, and if no other means is available, then you can start with skin to skin care. Otherwise, use the other mechanisms like radiant warmers, warm room temperature, and plastic bags and caps for those. And also use the radiant warmer in manual mode till there is no new evidence regarding that. So right now we are using the radiant warmer in manual mode for preparing the bed for the baby, and we should continue doing that because the group didn't find any new evidence regarding whether manual mode is better or servo control mode is better. Monitor the temperature of the baby specifically to prevent both hypo and hyperthermia. If more than 2 interventions are used, you are also using the thermal wrap, plastic wrap, and also mattresses, then there is the risk of hyperthermia also. So keep monitoring the temperature of the newborn every 15 minutes for the first 1 hour throughout the stabilization period. This is again a figure to just summarize the delivery room interventions which are there. And European Society now, ILCOR is adapted by various countries. The America adapts it, and we have seen the NRP 9th edition. The Europe has also adopted it and given some recommendations for their own countries. So this is one figure which summarizes all the interventions in the delivery room for maintaining the temperature. A denotes the use of room thermometer, digital thermometer to record the temperature of the delivery room. B is any external heat device, whether it's a radiant warmer or an incubator, but preferably an open care system so that resuscitation is done. C is use of any exothermic mattress if it's available and if it's possible. D is whenever you are giving any gas or any respiratory support at a high flow, then it should be heated and humidified. E is the use of cap, and F is if you are actually using the cling wrap to prevent any other external losses. So these are real-time pictures to show the use of the cling wrap in an extreme preterm baby, skin to skin care in a baby who is relatively bigger, 32 to 34 weeks, but it's still a preterm. And if available in some of the places, then this is the servo mattress, phase changing mattress for temperature maintenance that is there. So again, I wanted to just show to the post graduates that what are the recommendations in the published books and literature. So it says that the preterm baby can again be divided as per the gestation, less than 28 weeks at birth. Obviously, we are using radiant warmers and additional plastic bags. In week 1, we can use incubators for less than 28 weeks. Why we are going to week 1? Because this birth golden hour has to be sustained over the next few weeks. So this table can guide the practitioners and the postgraduates as to how to sustain the temperature regulation in the first week of life. For all other gestations also, the initial mode of warmth in the delivery room at birth is radiant warmer. And in babies who are more than 32 to 34 weeks of gestation, skin to skin care contact is advisable, provided they don't need any respiratory support for now. He's stable. So this is just to define the care warming devices which are there. We have radiant warmers, we have transport incubators from in which we transport the baby to NICU, and then use of exothermic mattress, the blanket warmer for that. So this actually finishes our thermoregulation, summarizes our thermoregulation part as per the latest guidelines and the updates. The next common management or the next crucial management in the first 10 minutes is how to manage the cord. The baby has come out, you have kept the room warm, you have actually dried the baby, you have used the cling wrap to receive the baby, and you have maintained all the warm chain systems as far as you could do till now. Now the baby has come out, what to do with the cord? So cord management, nowadays we have shifted to what is called deferred cord clamping. So deferred cord clamping has a lot of advantages. I'll first give the evidence for deferred cord clamping, and then I'll define what the ILCOR says for the management of preterm babies. So right from the physiology, so these two things are the physiology. What does it do? It will optimize the flow in the inferior vena cava and blood flow from the ductus venosus. It will optimize the pulmonary circulation and the cardiac output. And hence, these biological and physiological changes, what will they do? They will reduce the fluctuations in the cardiac output after load, thereby stabilizing the heart rate and the respiratory rate early. Hence, the mortality and the morbidities due to immediate cardiorespiratory instability are much more reduced, which leads to increased long-term outcomes also in terms of neurodevelopment. And apart from that, it also gives some immunological advantages and hematological advantages. We had a lot of evidence in the form of Cochrane for short-term as well as long-term outcomes for deferred cord clamping, which has now translated to the ILCOR guidelines. So this was the Cochrane in 2019 for short-term outcomes, where 20 studies showed the death as an outcome. Overall, 40 studies were included, but the death as an outcome was reported in 20 studies. It was shown that 27% reduction of death was there with deferred cord clamping. And not only short-term outcomes, the long-term outcomes at 18 months were also good in the deferred cord clamping group, as shown by the Bailey scores, and it was 70% improvement in the long-term outcomes. So what does the Coster say? We knew this evidence before the new guidelines came, but now Coster has defined the cord management in term and preterm babies both, but it applies to preterm babies in the golden hour as time-based decision, physiology-based decision, and as cord milking. So we are concerned mostly in the preterm babies with the time-based decision. Time-based means either we defer or we do immediate. So immediate they have defined as less than 15 seconds, and deferred cord clamping is no longer called delayed cord clamping, it's called deferred cord clamping. Initially they used to say at least 60 seconds. Now it's actually more certain that yes, it should be more than 60 seconds. Not at least, but it should be more than or equal to 1 minute before the respiratory support, which is deferred cord clamping. Cord milking can be intact or cut cord milking. I'll show why these terms are important for preterm babies in the golden hour. And the last modality is the middle column, which is intact cord. That means you are not doing anything to the cord in the placenta till the baby breathes. That may not be possible in preterm babies right now. So what does the latest guideline recommend in terms of golden hour management for cord clamping? So all vigorous babies, in all preterm vigorous babies less than 37 weeks gestation who do not require any resuscitation at birth, please defer the clamping of the cord by 60 seconds. It's a strong recommendation because the benefits in preterm are much more documented than benefits in term babies. Now, for non-vigorous babies, they have divided the group into 2 or 3 groups. So in non-vigorous late preterm babies, the scenario is different. We can do milking as an alternative. But for babies who are moderate preterm, which are 28 to 34 plus 6 weeks gestation, who could not be given deferred cord clamping because of any reason, there is an alternative that you can do intact cord milking. But it's a conditional recommendation yet. So you have to discuss in your unit, you have to discuss with the obstetricians and the national, we have to see the India NRP, which will come up soon. What do we do in India where the adverse outcomes with milking in the moderate preterms are still not available? So it's a conditional recommendation and the certainty of evidence is very low. So 28 to 34 plus 6 weeks, there is an alternative in non-vigorous babies where deferred cord clamping could not be done to do a milking, but then it is a conditional recommendation, a contextual recommendation depending on our context and our own country guidelines. One thing is for sure, in less than 28 weeks gestation, please do not do any cord milking. Whether it's cut cord or intact cord, do not do cord milking because it has harms of increased intraventricular hemorrhage. So in preterm babies, if you compare milking, intact cord milking versus deferred cord clamping, few literature which is already available in form of subgroup analysis, no differences in short-term outcomes in terms of in terms of blood transfusion need or levels of hemoglobin hematocrit, and also no difference in long-term outcome. Definite harm is there in the subgroup of less than 28 weeks. So do not do milking in less than 28 weeks in any baby who is not cried after birth. And regarding the intact cord or placental resuscitation for preterm babies, there is no statement provided by the coster, so please do not practice this also. So in less than 28 weeks, please do not do any milking. You just have to resuscitate the baby. 28 to 34 plus 6 weeks in babies who have not cried, you can try cord milking, intact cord milking, and then proceed resuscitating along with that. And in less than 37 weeks who have cried, you have to do a deferred cord clamping. In certain special situations like twins, Rh negative pregnancies, congenital anomalies, since most of these cases were excluded in most of the literature and most of the studies and RCTs, the coster has not given any evidence. They suggest that we discuss with the obstetricians and we suggest individualized decision based on the severity of the condition and assessment of maternal and neonatal risk. Regarding cesareans and vaginal deliveries, the deferred cord clamping has been found to be safe in vigorous babies who have cried after birth, so DCC is safe. So we are searching for answers in terms of milking in a subgroup of 28 to 34 weeks. So there are some few trials which are still ongoing, like DOXY trial, which has enrolled the babies who are extremely preterm with DCC with oxygen and extremely low gestation age, and they are going to look at the outcome of reduction of the hypoxia. Then again, this is a preterm VPI trial, a 3-arm RCT, where milking is being compared, cut cord versus intact cord in babies who are less than 32 weeks. So we'll wait for these results to come. Till then, for all vigorous babies, do deferred cord clamping. For non-vigorous babies, milking can be done based on the condition and the context-specific guidelines in 28 to 34. No milking in less than 28 weeks gestation. So these are the 3 take points for cord management. So these 2 things are done, the thermal part, the cord part. Now the baby is with you. How do you resuscitate the baby? So this is the new guideline, new NRP flowchart as per the American Academy of Pediatrics, the 9th edition. which they have adapted from the ILCOR or the evidence-based document. So here the new thing which is added is cord management has been added right in the flowchart upfront after the birth, and some of the initial steps are changed. So we can go through this NRP update in detail and some other forum actually, but follow the standard resuscitation guidelines. Now we are following the guidelines. What should be the initial FiO2? Because oxygen we know is a drug, is a medicine, and both excessive oxygen as well as low oxygen administration can be dangerous for this vulnerable group. So we have to try actually entire range from 21 to 100% in preterm babies is the crux of the guideline which has given, because recent guidelines which they say is even 30% may be harmful, the 100% is associated with more survival. So there are a lot of conflicting evidence coming from the systematic review. What does the Coster or the ILCOR 2025 suggest, or they summarize it like this, that among newborn infants less than 32 weeks gestation, begin with more than or equal to 30% oxygen. Again, it's a weak recommendation based on low certainty evidence. And for the babies who are 32 to 34 plus 6 weeks, moderate preterm babies, the evidence is insufficient. So we need to still do research on one versus another, 30 versus 60, 30 versus 90, 30 versus 100. So there are a lot of scope for research in this subgroup. But for practical implications, what do we do? For more than or equal to 35 weeks, we start with 21% FiO2. For 32 to 34 weeks gestation, we start with an FiO2 between 21 to 30%. And for very preterm babies less than 32 weeks gestation, we start with an FiO2 of more than 30%. So this is the change which has come. In less than 32 weeks gestation, start with an FiO2 of 30% and then increase till based on the target oxygen saturations, right? So the task force did conclude that there is certain uncertainty over the optimal initial FiO2 that needs to be used in 32 to 34 weeks, and we need to investigate or research the entire range. But practical implication is this: for less than 32 weeks, start with 30% and increase as per the target oxygen saturation. Just to touch upon the most recent torpedo trial of 30 versus 60%, there was no difference in death at 36 weeks of gestation or brain injury at 36 weeks postnatal gestation when FiO2 of 30 versus 60 was used. We yet need to see the powered studies on ROP and other long-term outcomes in terms of BPD and neurodevelopmental outcomes also. It was a multi-centric study in 6 countries. Fernandez from India was one of the centers from India. So all this FiO2 business actually depends on the target oxygens, although it again is a matter of investigation whether these target oxygen saturations are well documented or not, or whether they are related to clinical outcomes or not. But for now, we should follow the preterm WHO guidelines for preterm target saturations, which are 5% lesser than the term target saturations, which we saw in the flow chart. So the preterm target saturations actually begins with 2 minutes. At the end of 2 minutes, we should target anywhere between 75 and it should reach at 10 minutes, it should reach 95%. So these are some of the target guidelines as per the WHO. So we are ventilating, we are giving FiO2, but what device to use? So again, we have 2 types of devices. Most of us are aware of it. It's a fixed pressure device, which is a T-piece, which is a flow dependent device. And there is a variable pressure. Why it's a variable pressure? We have to use our own hands manually to give the breathing through the ambu bag or the self-inflating bag. The fixed pressure devices, because they give fixed pressure, we can be gentle, we can titrate accordingly. They have lower mortality, lower morbidities in terms of intubation needs, surfactant requirement, and mechanical ventilation rates, and subsequently lesser BPD and PVL. But whenever you are using a T-piece, remember to keep the self-inflating bag as a backup, because it's a flow-dependent device. The T-piece resuscitator, it may fail, or you may be running out of flow, or it may not work in some situations. So always keep a ambu bag, self-inflating bag as a backup. That's the recommendation. What should be the best interface for providing positive pressure ventilation? The face mask versus supraglottic airway. A lot of emphasis and a lot of research was done by the Coster group on supraglottic airways, and they concluded that LMA has certain limitations, the laryngeal mask airway, that the size is not available for less than 34 to 32 weeks gestation, the smaller size. the skill and the expertise to use it may be different. So still, self-inflating bag with face mask or a TP resuscitator with face mask is the best interface, although both have their own limitations. Other few updates, minor updates, are that the ventilation rate should be between 30 to 60 instead of 40 to 60. This is as per the AAP 9th edition. The initial PIP in 32 weeks, who are more than 32 weeks, should be between 25 to 30 as measured by the TP's resuscitator. And the babies, preterm babies who are less than 32 weeks, it should be 20 to 25. The ET size as per the weight is also a little modified. It has been a little more made a little more precise, and these are the guidelines as given in the table. The depth of the ET is also important because it is actually best practice to optimally ventilate the baby. We should not be over inserting or under inserting the endotracheal tube. The landmark is now changed to anterior edge of the upper maxillary gum instead of the lip to tip distance for fixation of the ET. So now we have resuscitated, we have given ventilation, we have given positive pressure, or we have given CPAP to the baby. We'll come to the CPAP later also. So now what to do? We have to transport the baby, and the goal should be to transport in as stable form as possible and as early as possible to the controlled NICU environment. So we should have a pre-warmed incubator. The baby, as far as possible, should be wrapped in a cling wrap. Continuous pulse ox monitoring should be there, and continuous TP's resuscitator should be there. All the monitors should be attached. At the time of admission, do document the admission temperature. As we have seen, it's an independent marker of mortality and morbidity, and also have your audit sheets ready. Now the baby is with you. What to do now within the first 30 to 60 minutes? So there are four main domains which we should look at: the respiratory, cardiovascular, the nutrition part, and the asepsis and counseling part throughout. So respiratory stabilization again has 2 or 3 domains. CPAP we have started, and we should start in the delivery room as per the resuscitation flow chart. The less than 32 weeks gestation who have labored breathing, those who are spontaneously breathing, they should be started with continuous positive airway pressure. Non-invasive ventilation should be started, not intubation preferably. It should be started in delivery room. Following that, we see the threshold of surfactant administration, whether we should administer the surfactant at 30% or 40%. The European guidelines say 30% for the first dose, and repeat dose it increases. The method, we know that the less invasive surfactant administration is obviously has lesser morbidity in terms of BPD versus the classical intubate, surfactant, give surfactant and extubate. Instead of that, LISA is now the choice of process for giving the surfactant. Early caffeine is known to be neuroprotective as well as lung protective. So regarding the surfactant therapy, nowadays the role of prophylactic surfactant has reduced a lot with a good CPAP available in the delivery room. So when all the studies were evaluated, no benefits of prophylactic surfactant could be demonstrated. Rather, early CPAP was found to be more protective, and early rescue surfactant is found to be again reducing the risk of overall mortality in the baby. We know the types of surfactant. I'll not go into details. I'll just wanted to touch upon it because it's sometimes you may need to give surfactant within the first 1 hour, okay, when the baby has severe RDS. So these are some of the compositions and the doses, available formulations, and the cost for your information. And as I said, the European guidelines say, the blue box shows the European guidelines for threshold of surfactant therapy. They say the surfactant should be given when the FiO2 need is more than 30% and the CPAP pressure is more than 6 centimeter of water. Whereas the NNF CPG guidelines, they say that it says the same, but they say that LISA, if the skill is not available, you better do insure. But be confident in the procedure which you are doing. Some of the units, they may not be very confident in giving LISA, surfactant through LISA, so you can do insure within 2 hours. And again, the threshold is the same, FiO2 of 30% and a pressure of more than 6. So that is the guideline as per the European and the NNF CPG. So beyond the delivery room, the target oxygen saturation should again be monitored. It is between 90 to 94%, and the alarm limit should be set between 89 to 95% to actually prevent BPDs, ROP, and NEC. CPAP pressures, how much to start? So the European guidelines say the starting pressures between 6 to 8, 5 to 9, and the NNF CPG guidelines, they say initial pressures of 5 centimeter of water, and post extubation it can be 6 centimeters if you are trying to do insure. You can just increase after extubation, but the initial pressures in the delivery room should be 5 centimeter of water. HFNC as a primary therapy is still not recommended as per the NNF CPG guidelines. The European guidelines also don't give any concrete guidelines for that. NIPPV in certain groups like less than 28 weeks gestation, you can use primary method of synchronized NIPPV, and there are upcoming modes also. So the crux is that you should be using non-invasive ventilation in the first 1 hour. I'll not go into the details of all the invasive and the non-invasive part of ventilation, but the respiratory stabilization should be as gentle as possible. The pressures should be started as per the standard guidelines, and monitoring is a must. So use non-invasive modes as far as possible. Give surfactant as early as possible within the first 1 to 2 hours. The interfaces, the prongs remain the interfaces of choice, short binasal prongs. Cardiovascular stabilization, we all know, monitor the heart rate, the basics which we teach. The heart rate, CFT, urine output, blood pressures, the overall color of the baby, core and the peripheral temperature. Monitor it closely. Do not go into too much of invasive investigations, but monitor the clinical part, timely detect it, and close monitoring of vitals and use of point of care eco devices as available. Okay. Nutrition, don't forget, please. Even if the baby is less than 32, less than 28 weeks, talk to the mother, talk to the parents, get the colostrum, get early express breast milk. Even a drop, dose dependent benefits of breast milk is well known, and our unit is actually a strong propagator of use of colostrum and early express breast milk, and it improves the outcomes very much in terms of even neuroprotection and lung protection. Early KMC and immediate KMC, I don't have to talk in Gujarat much because it's one of the leading states which is actually practicing KMC, and it's ready for immediate KMC also, which is an extension of early KMC starting right from the delivery room itself. Okay, so please remember these interventions which not only improve the mother's own milk but also improves the baby's long-term and short-term outcomes. Routine treatment of PDA is again a chapter on its own, but it's not recommended as per the European guidelines. So don't just keep a watch on the cause of shock. The crux is that keep monitoring non-invasively as well as invasively as and when indicated. And antibiotics and nutrition, please be very, very judicious in use of antibiotics. Have your own unit protocol about the risk factors in the mother. When do you want to start antibiotics in the first hour or after birth? Very rare indications of considering antibiotics right at birth or in the golden hour. So please be very judicious. Have a close watch on the baby. Do all the other things which are important like temperature, respiratory management, optimization of the cord, and all these things. If you do those well, the babies are actually stabilized and they move in the auto mode. We do not need to give or investigate much. Ensure proper nutrition, glucose monitoring, IV fluids of 70-80 ml per kg, those who need it, or enteral feeds, and fluids must be tailored according to the weight. TPN only when indicated. I know most of the units, many of the units in less than 1000 and less than 28 weeks, they are starting total parental nutrition, aggressive nutrition. So placement of a good central peripherally placed central line aseptically is very important. Good dose of amino acid and lipids as per the dose which are there in the guidelines should be given in those babies where indicated. We ourselves are starting on early enteral feeding only. So family counseling is very important in 3 domains. First of all, antenatally, when you are called by the obstetrician, just talk to the mother and the father and the parents about the risk assessment right from the antenatal or the immediate peripartum period. That this is the baby, the fetal weight, what are the likely anticipation of resuscitation and the NICU stay. Communicate about those risks and the likely stay the baby may require, and keep providing ongoing support, SOS, as and when required to the family. And this should be part of your golden hour, because the rapport you build with the family and the mother at the time of the birth, it goes a long way in all the evidence-based practices. The mother will express her feed better, give colostrum, will be providing KMC better, and we have seen and experienced it. The baby will be discharged early. There are a lot of QI projects, quality improvement projects on golden hour, which are there in all the age groups: extreme low birth weight, extreme premature babies, very preterm babies. And I have enumerated most of these, and they have done it in a time-based manner. First 10 minutes, 10 to 30 minutes, 30 to 60 minutes. And the outcomes have been very good, and it has been demonstrated globally as well as in our own country as well. So it is evidence-based, the golden hour time. And the seeds of lung protection and neuroprotection, they start right in the first hour. You see, most of these interventions, they go a long way in prevention of BPD, ROP, and also shorter duration of stay. And some of them I have summarized, like gentle non-invasive ventilation, use of fixed pressure devices, only caffeine in the first 1 hour to 24 hours, timely surfactant, pre-golden hour counseling, management, thermoregulation, nutrition, and prevention of sepsis. Both are common. The lung and the brain protection is common because the gentler you are, more evidence based and more team based approach you do, avoiding fluctuations, avoiding too jerky handling of the baby, following the thresholds of interventions, the more dividends it will be paying. So it is indeed a golden hour in actually preventing the mortality and the morbidity. And I go back to my first few slides that these are the key take home messages also. Prepare well. First 10 minutes, remember three things: thermoregulation, cord management, and resuscitation. The next half an hour, you have to shift the baby to your NICU, a neonatal care area. And the first 1 hour, as indicated, intervene in terms of respiratory support, surfactant, nutrition, cardiovascular intervention, and asepsis should be throughout. It should be there. So you can actually go through the ILCOR update, which Somsekhar sir is the corresponding author of, and the 2025 update. The whole document is also there, and this is just a summary of that. And there is the ninth edition, and this ILCOR has, and the Coster guidelines have been adapted by AAP as ninth edition. We shall be coming with our one soon, India one. And this is again IAP NNF initiative, the quick reference guidelines in neonatology. The next one to be released is again golden hour management of premature neonates. And we are still in the editing process of that also. So please go through these. These are good, quick reference reading material for you all. Thank you so much, and I'll be happy to take questions.
Thank you very much, ma'am, for again a great explanation regarding all the recent guideline also, and good insights regarding the bedside management of preterm care. And it's very good for the postgraduate, of course, for the postgraduate, those who are not doing them sometimes as silly mistakes. So it will be very helpful for the postgraduate who are posting in the neonatal intensive care unit. Thank you very much. And we will take Shreyansi, is there any questions? Shreyansi?
Sir, hello.
Is there any questions in this delegate group?
Yes, sir. Just allow me a minute. Let me check.
So, Pratima, I'd like to ask, is there any specific gestational age below which we should or we must use incubator rather than putting a baby in open care systems?
Whatever I could search, 28, less than 28 weeks and less than 1000 grams, they say that closed system is better, sir, incubator, in terms of insensible losses, and 70% with 70% relative humidity in the incubator, sir. Less than 28 weeks it was.
Otherwise, in late preterm, there is no evidence. Both are equally placed.
Both are equally placed. Yes, sir.
Sir, I'm putting in the chat box. We have received one question.
Okay.
Okay, Dr. Indu, ma'am, any information on NEC and probiotics? So, Dr. Indu, recently we reviewed that also. So, probiotics are again contextual recommendation, ma'am. As per the NNF evidence-based guidelines which came out in 2023, it is a conditional recommendation where the units have high incidence of NEC. Now, what do we mean by high incidence? Wherever the need for surgical NEC type more than stage 2A, 2B. If the staging is more than 2A, 2B, the percentage is 5% or more in the unit, then they say that probiotics are useful. Uh, Otherwise, in units where NEC rates are as it is very low, less than 1%, 2%, and it's just a suspect NEC or a feed intolerance, perhaps the benefits are not that much. So the units which are using, they are using a combination of bifido and lactobacillus bacteria in less than 32 and less than 1500 grams whenever the baby is on some amount of feeds. We cannot give to the baby who is nil per orally. So this was the one which we reviewed 2 weeks back in one of the journal clubs. So that is it, ma'am. There is evidence, but again, the species specific evidence is not there. So hence the conditional recommendation is there. Naveen sir, any addition to this probiotics?
No, you have said quite rightly that we need to take care of the harms associated with the probiotics also. Uh, some of the units that including us also have seen the harms associated with the probiotics also. So you need to be careful about that because you are supplementing something if that is that already has infection or a compromised intestines. The bacteria gets loaded with the intestine gets loaded with the bacteria and multiplies there. So at least we are not using as routine probiotic in any even the smaller babies also. We used it in between, but then stopped using it because of one or two misincidents happening attributed to probiotics.
Uma ma'am, Dr.
So
Biraj.
maybe in a high risk situation you
Yes.
can use it, but very carefully. Very carefully.
We are going to have
Though if you
Out of
see
the
some of
context,
the
actually.
units of Australia, they are using it routinely, and in fact some of the formulas they are saying that even the cesarean section normal term babies should be given in this specific formula containing this specific probiotic. But
Yes.
that's yes, there
During
is a formula.
Mahaniyokon,
Yeah, that is
Westbourne
common.
Yeah,
Neocon, Dr. Sanjay was like very much for the probiotics. He's a
yeah.
pioneer in that.
So
So,
there is a difference of opinion, and that is good that there is a difference of opinion that it is not a strictly one liner that you use it or you do
I
not
think
use
our
it.
next expert talk is regarding nutrition, right? NECU. So that is recent.
yes, so let's keep it
After
for
1
that.
hour, we'll be jumping to
That's after
nutrition.
golden hour. Yeah, that should
Yeah.
be covered later on.
Definitely, Dr. Indu will have a better and more discussion related to that in our next expert talk. That would be next month, second Wednesday.
Yes. And we'll also discuss the role of human milk bank and probiotics.
Yeah. So with this,
So human milk itself has a lot of
Yeah,
probiotics.
Yes,
If you are
yes.
using that, then probably your otherwise
We don't
incidence of
require it
NEC
all.
and sepsis
Yes,
and it
exactly.
goes down significantly.
Yes.
So having a human milk bank, EBM first, and human milk bank if EBM is not available, especially the babies born outside transferred and from a long distance, then that possibility you should consider.
So it was wonderful discussion and wonderful presentation, Dr. Pratima. Thank you very much. Dr. Uma, madam, thanks for accepting the invitation. Dr. Naveen, sir, thank you very much for being here with us and having a fruitful discussion. Thank you, Shwetal, madam, being a project in charge for planning this talk. Thank you, Praful, for coordination. Thank you, Shreyansi, clarinet. Thank you, Yogesh sir is not there, Rona, Purvi, and rest all delegates, audience who have attended this talk. And this definitely recordings will be available, will be put on our YouTube channel, the NNF Gujarat, and we'll be sharing it soon in groups as well. So thank you everyone. And our next talk, that is again next Wednesday, is either case presentation or journal. And for this month, we are going to have a journal discussion that is by Dr. Rachina, who is a fellow at Arpan Newborn Care Center. So same day, same time, next Wednesday at 3:30 p.m. Hope to see you all. And thank you very much. Thank you all.
Thank you so much. Thank you.
Yeah, thank you.
Bye-bye.
Thank you,
Thank
ma'am.
Wish
Thank
you
you so
all
much,
good
you
everyone.
evening.
all.
Yeah.
Bye.
Thank you so much, everyone, for giving us the opportunity to host the session. Thank you. Have a nice day.
Okay.